Hello, and welcome to our HealthEd Livestream. Is it just back pain or something more? I'm Cassie Schaefer, CEO of the Spondylitis Association of America, and I'm so happy you're joining us today. This program is for anyone who's been living with chronic back pain, sometimes for years, without clear answers. We know how frustrating that can be, and we also know that not all back pain is the same. Today's program has been specifically designed to help you better understand your pain. You'll learn about the key differences between mechanical and inflammatory back pain. And you'll be introduced to a group of conditions called spondyloarthritis, including axial spondyloarthritis, which is frequently misdiagnosed or undiagnosed, delaying critical treatment time. If you recognize any symptoms that are discussed during the program today, consider jotting down key questions to discuss with your healthcare provider. You'll hear from medical experts, patient advocates, and people with lived experience who understand this journey firsthand. Throughout the program, we will encourage you to visit our website, where you can connect with a comprehensive hub of educational resources, including our axial spondyloarthritis screening tool. Dr. Abjit Danve developed this tool using published research to help raise awareness about inflammatory back pain. The screening tool is for education purposes only, and it does not provide a diagnosis. It is a starting point to help empower you to identify your specific symptoms and prepare for a more informed conversation with a healthcare professional. Thank you for joining us on this journey. And a special thank you to AbbVie for helping to make this program possible with an independent patient education grant. We hope today's program helps you feel more informed, more prepared, and closer to finding the answers you deserve. We believe that no one should have to face this disease alone. Following today's program, we invite you to stay connected with us through our website, our support groups, and our online community. Thank you again for joining us for this important conversation.
All right. Hi, everyone. I'm Dr. Charles Odonkor. I'm an assistant professor of orthopedics and rehab at Yale School of Medicine, where I also do interventional pain and musculoskeletal health. I'm also co-director of clinical research in the department. Before I begin, I would like to thank the Spondylitis Association for this wonderful opportunity to give this presentation. In my own practice at Yale, I do see patients with conditions affecting the chronic lower back, among others. So I'm very thrilled to be here to give this presentation. Okay, so today's presentation is going to be about causes of chronic back pain and going beyond the basics. I hope to give an overview in this presentation on the various causes of chronic back pain, including mechanical causes, inflammatory causes, neuropathic, as well as myofascial causes of chronic low back pain. Now, as most of you know, chronic low back pain is very common. It's the number one reason why patients see medical attention in the United States. About every 8 in 10 people experience back pain at some point in their lifetime. And this is a very, very expensive condition. It costs the United States about $650 billion annually. And it's the leading cause of opioid use in the United States. So back pain is incredibly common, it's very expensive, and unfortunately, a lot of folks have to rely on opioids to help manage their back pain. It's a very, very diverse condition, meaning that patients with back pain come in various forms and different characteristics of presentation. Typically, as displayed here, back pain can present either in the small of the back, It can also go up and down the entire spine. And there are times that, depending on what the cause is, it may be associated with aches and pains in different joints throughout the body. I'm sure that some of you are familiar with conditions like fibromyalgia that tends to not just affect the lower back, but affects the entire body. And then there are conditions like spondyloarthritis, as well as compression of the vertebrae, etc. So not all lower back pain is the same. And some of the ways that it presents. A very common one here is listed is disc-related back pain. The typical onset usually would be in the setting of lifting something very heavy. Most of the time, I would hear patients say that, they were in the gym trying to do exercise, they lifted some weights and they felt a sharp pain in the back and they're going down the leg. Things that typically would help with this particular type of pain include rest, physical therapy, and avoid prolonged sitting. The next common cause of back pain is the SI joint, which stands for the sacroiliac joint. Typically, you will see this postpartum, so after delivery, or involving twisting, turning injuries. The key symptoms would be pain in the buttock, typically on one side. And one way to improve this type of pain is exercise to stabilize the sacrum or receiving injections. The other common type is just related to muscle aches. This is typically a result from overwork or deconditioning. It typically tends to get worse at the end of the day. One way to get it better is through core strengthening, again, exercise. The other type of common presentation is fibromyalgia, which I mentioned before. This is a little bit different because it tends to affect the entire body. So typically, you would have aches and pains everywhere, not just your lower back. Other symptoms that go with this include fatigue, poor sleep, and typically, again, like we've seen before, exercise tends to help with this. Also, we have medications. And then there's CBT, it's a psychiatric uh, method to try to help the way your brain interprets pain. And then the last common cause of back pain is inflammatory, typically presents with morning stiffness. And as the day moves on with movement, it tends to get better. You can also take some NSAIDs, Motrin, ibuprofen. And this type of pain typically involves care from a rheumatology doctor because you might have to have some lab work done to look at the inflammatory markers in your body. Now, beyond the back, there are times that pain will be associated with other areas of your body. So here I'm showing, typically if you have pain that is constant and is not related to any type of position, it's typically, you see this in patients who've undergone what we call spine surgery and they develop something called failed back surgery syndrome. You might also see this type of pain symptom in patients who have complex regional pain syndrome or nerve impingement, which is what the radiculopathy is standing for. Another way that the back pain can present is if the pain gets better when you're leaning forward. We call this the shopping cart sign. You go around in the mall, you see folks leaning over their shopping cart. Some of it is probably because it helps them feel better. The typical cause of that is lumbar stenosis. And what it means is that the space through which the nerves come out have become very narrow. And that's part of why when you lean forward, you're opening the space up, and that gives you temporary relief. The next type is pain that is related to twisting and turning. So let's say you're leaning over to reach over for something. It seems to get better with rest. This is typically a pain that is coming from the facet joints. These are the joints of your spine that allow you to twist and turn. And over time, we develop arthritis in these joints, and that tends to cause some pain as well. And then the last type of pain is what we call the vertebrogenic pain. This is pain that usually you would see in your lower back with prolonged sitting or prolonged standing. So for folks, for example, if you have to drive long distances or you're on a plane flight, you get out, your back feels very stiff, or you're at home trying to, prepare a meal, standing on your feet in the kitchen. After a few minutes, half an hour or so, you want to go sit back down because your back is killing you. And this type of pain is usually from the vertebrae, and we call it vertebrogenic low back pain. Down here, I've listed all the different various interventions that are available to treat the different types of pain, which we might not really get into today. But the good news is that regardless of the source of the pain, there are various advanced options that are available to try to get this type of pain better. So at this point, I want to go a bit into the neuroscience of back pain, because over the years, we're starting to understand that back pain is not simply back pain. In fact, the evidence is suggesting that it does change how your brain is wired and how your nervous system is working. So, the last 20 years, there's been a lot of research coming out suggesting that the brain undergoes what we call neuroplastic changes, where the nervous system becomes remolded depending on how much pain you've been in. And this simply means that your brain structure is changing, meaning, your brain has gray matter, and that gray matter undergoes several alterations the longer you have been in back pain. And not just that, it changes the network of nerves that work together along the pain pathways. And so this means that a lot of your sensory fibers become overactivated. And just like the way, your heart has a certain cadence and rhythm to it, your nerves are the same. Unfortunately, in chronic back pain, the threshold of activation is so low that anything triggers the pain pathway and it becomes hypersensitive. And so we're starting to see that if you take a group of patients that have chronic low back pain, and then you compare them to another group that doesn't have low back pain, there are several markers that light up in the nervous system among the patients who have chronic low back pain, and the pain tends to be more persistent. So we are beginning to understand that, back pain is not just a mechanical problem or inflammatory problem, it's also a nervous system problem, because you have overactivation of the central nervous system and activation of the peripheral nervous system, and you develop sensitization of these two. And this is why in some patients, no matter what you do, they don't seem to get better. And that's because we are not treating a very vital aspect of the pain, which is the nervous system. The emerging data shows that in patients who have chronic low back pain, there's a change in the way that the nervous system is processing the pain signal. And not just that, but it also affects the way that the motor nerves are working. And so there are times that, for people who have chronic back pain, you find that your mobility becomes significantly limited. And that's because of the way that the nervous system is working. The nerves become much slower in activation. They don't conduct as well as they should. And then indirectly, because the nerves feed the muscle, your muscle also starts to get weak. And so you start to develop what we call muscle dysfunction. And one of the big muscle in your lower back is called the multifidus. This is really the core muscle that controls how your body holds itself up. So in terms of your posture, how you twist and turn, it's a very, very important muscle. The other function of the multifidus is that it's a proprioceptor. So what that means is that it gives you a sense of balance and a sense of steadiness. And so there are times that, folks who have had chronic low back pain for a long time, one of the complaints that they present with is that they find that their walk and their gait or balance is not great. And that's because you're starting to lose function of the multifidus. In addition, there's also the transverse abdominals. Basically, these are the ab muscles, right? If you have a six pack, it's because you have very well developed transverse abdominals muscle. And unfortunately, once the multifidus muscle starts to atrophy, indirectly, it impacts the transverse abdominis. And then over time, both of these muscles undergo atrophy, meaning that it breaks down, it becomes weaker, and it starts to fall apart. And then once this happens, the mechanisms by which these muscles get activated becomes inhibited. And so you start having fatty infiltration of the muscle. And then that then leads to inflammatory changes in the muscle as well. So the muscle quality, its ability to contract, relax, becomes significantly inhibited. So we are now getting an understanding that it's not just the mechanical aspect of the pain, it impacts the nervous system and also the function, the integrity and quality of the muscle in the lower back and in the abdomen. And an important point here is sometimes, we talk to patients about exercise, sometimes they don't really see the correlation between the exercise and the fact that their pain is going to get better. But this is actually showing us the link between having really strong core muscle in the abdomen, as well as great multifidus muscle in the lower back. So what are some ways to manage chronic low back pain? Now, because my base specialty is physiatry, we always think about functional ways to incorporate some rehabilitation strategies, as well as behavioral modifications. Now, behavioral modification, for example, if you have a sedentary lifestyle, we try to get you up and walking. You can walk maybe half a mile a day, incorporate exercise into your routine. Behavioral modification also incorporates diet, right? And then healthy behaviors like, not smoking, because that drives inflammation in the body. And then cutting out a lot of processed foods, because these, again, tend to promote inflammation. And then we have some other strategies, for example, mindfulness, relaxation techniques, breathing techniques, yoga, Tai Chi. These are all ways to try to help cope and manage the source of the pain. The last one is that an effective strategy involves many, many disciplines. So you're going to see a pain specialist, you see a rheumatologist, you see a physical therapist, occupational therapist, a psychologist, multiple different aspects and specialties bring their expertise to managing this very complex entity, which is chronic low back pain. So in summary, in terms of the neuroscience aspect, the emerging evidence seems to suggest that chronic low back pain involves a complex interplay between the peripheral and nervous system, and an effective strategy to help overcome chronic pain would involve targeting different aspects of the central and the nervous system for patients to get remedy and to feel better from their chronic low back pain. So some other treatment approaches, which we kind of have touched on, again, exercise physical therapy is very key. Anti-inflammatory medications do have a role within some limits, because you don't want to rely on anti-inflammatory medications because of potential side effects on the GI system. There are also available nerve blocks and joint injections, sometimes with steroids, that do help. And then pacing oneself in terms of activity. So a lot of my folks who do physical work, physical labor, sometimes I would say if you can take a break, every 2 hours or so, take 10, 15-minute break just to give your body a rest. That's very helpful to offload some of the stress on the body. Also, stress management is very, very important. So relaxation, breathing techniques, going for massage, acupuncture, these are all ways to help offload stress on the body. And then mental health and good quality sleep is very important. An important aspect that I didn't highlight in the point about the nervous system is the center in your brain that controls sleep, the reticular activating center, is the same center that controls pain. And so it's no surprise that for people who are a lot of pain, sometimes they have a very hard time getting a restful sleep at night because the center is getting overactivated. And this creates a vicious cycle, because the less sleep you get, the worse your pain gets. And once your pain gets worse, you're not going to be able to sleep well. So these are they go hand in hand. But learning how to practice very good sleep hygiene, right? Turning off the lights, not watching TV, falling asleep behind the TV before you go to sleep. These are all very healthy ways to encourage and maintain good sleep hygiene, which then indirectly has benefit for your chronic pain. And I know that later on, there's going to be a more detailed presentation on inflammatory back pain. But just to touch on it briefly, this is a pain that typically it's early onset before age 40. And typically, like I said, morning stiffness is a classic hallmark. It tends to get better over the course of the day. It's also the type of pain that tends to wake you up at nighttime. It tends to alternate and can be asymmetric. Sometimes starts on one side of the body, and then it seems like it tends to travel and move around. And there's typically an association of previous family history of this type of problem. It goes with conditions like inflammatory bowel disease, psoriasis, or rheumatoid disease, or many other types of autoimmune conditions. So when should you try to seek medical care or seek expert opinion when you've had pain? You should do that typically if the pain has been present constantly for 3 months or more, despite taking over-the-counter medications, despite doing exercise, despite doing physical therapy. You should definitely seek medical care. If there's any other symptoms like weakness, numbness, bladder issues, where you have to go right away if you can't hold your urine, then that seems to suggest that there's some underlying cause or factor, and this is going to require advanced diagnostic like imaging or some kind of blood work. In addition, if you do have other symptoms like fevers, chills, night sweats, weight loss, these tend to point to underlying causes, things like maybe inflammatory conditions or autoimmune conditions or cancer, and this warrants further and prompt urgent care. The common modalities to image the spine typically would be x-rays first, and then subsequently, if more detailed structural evaluation is needed, then you're going to get an MRI. And together, that provides some clues as to the potential cause and source of the pain. So, what are some common pitfalls that sometimes hinder appropriate evaluation or timely evaluation of patients who have chronic low back pain? The most common one is that a lot of the times, patients who have inflammatory source of pain can sometimes be overlooked, and it's very common to associate the pain with some type of mechanical source or cause. But if the pain seems to really be awful in the morning and it's constant, every morning you wake up, most often than not, it is not a mechanical problem. Most often than not, it's an inflammatory problem, and this should alert you to seeking further medical care for that. Unfortunately, sometimes we tend to over rely on what the x-rays are showing. And, how many patients are frustrated? They go to the doctor tells you all your imaging looks fine, there's nothing wrong with your spine, and yet you still have the pain. And so, just because the spine looks fine on x-ray doesn't necessarily mean that there's nothing going on in your body. And it could be that, the reason we are not seeing anything on the x-rays is because you are just at a very early stage of the problem, and this doesn't show up on the x-ray. Now, the converse is that, just because you have a lot of arthritis on your x-ray doesn't necessarily mean that that is what is causing your problem, okay? And ignoring things like night sweats, chills, weakness, numbness, this can be problematic because it may be pointing to some very serious underlying cause. For example, cancer or infection or some other thing, injury to the spinal cord. So these symptoms, if you do have them, should really be treated seriously and kindly seek urgent medical care. Lastly, we also have psychosocial factors, things like depression, mental health problems, fear avoidance, poor self-efficacy. These are things that we often don't tend to speak or talk about, but play a very, very big important role in terms of how it impacts the nervous system and how that indirectly also influences your experience of back pain. So pain is not just, a physical thing, but there's also a huge emotional aspect of pain, chronic low back pain. Now, with all of that said, there's still, promise, there's still hope. And how do you talk to your doctor? Typically, if you come to your doctor and you have a pain diary, that tends to really help because then you have very accurate documentation of how often you have the pain, what time of day you often experience it, what makes it worse, what makes it better. Do you have stiffness in the morning? Is the pain there all the time? Does it get worse with movement? Does it get better with movement? So the more detailed information you have, the more helpful it will be for your doctor as they listen to your story to try to put together what could be driving or causing your pain. Also, when do you seek care? Hopefully at the end of this talk, you would know that if you have had pain that is lasting more than 3 months, is waking you up at night, or pain that is worse with stiffness, this means that this is time for you to seek medical care. And the more accurate records that you keep, the easier it is going to be for you to be able to communicate with your doctor or your physician. And early communication and often communication is very key because the more data information you give to your provider, the more equipped they're going to be to try to sort out and figure out what's driving your pain. And then inadvertently, they can come up with a solution or a treatment plan for you. And sometimes, when you have pain, it can be a very lonely experience because it can feel like nobody understands what you're going through and that you are going through all of this alone. So sometimes joining like online support groups, like I'm sure the Spondylitis Association has support groups and resources that are available, that sometimes can help. Because again, like I said, chronic pain does have a huge, huge emotional component to it. And that has a big impact on the nervous system. So most chronic back pain can be improved with the appropriate and timely diagnosis. Early recognition is very important, and a multidisciplinary approach is very essential. With the right diagnosis and the appropriate timely intervention, you can find the right answers. And also, you can partner with support groups as well as your physician to try to get you back on track so you can live and enjoy a good quality of life. All right. Thank you very much again to the audience and to the Spondylitis Association for this opportunity to share this presentation. I hope you found it helpful and you took some pearls from it that would help you in your journey as you seek further care for your chronic low back pain. Thank you very much.
Hello, everybody. My name is Raj Sengupta. I'm a consultant rheumatologist from the Royal National Hospital for Rheumatic Diseases in Bath. And thanks go to the Spondylitis Association for inviting me to speak today. I'm going to focus mainly on the differences between inflammatory and mechanical back pain and consider whether anyone listening to this might have axial spondyloarthritis. So in this talk, I'm going to look at the key differences between mechanical and inflammatory back pain. I'm going to think about some red flags, some key features that might suggest an inflammatory cause. I'm going to go through in a little bit of detail why inflammatory back pain and the diagnosis of axial spondyloarthritis is missed or delayed. And then I'm going to come on to when to really seek a rheumatology referral to get the diagnosis of axial spondyloarthritis. So the normal pathway, at least in the UK, goes like this. Someone has back pain, and then they might go and see the general practitioner. In the UK, we now have first contact practitioners who are physiotherapists with an expertise in assessing and diagnosing back conditions. And many of our patients, up to 40% of people with back pain, go and see an osteopath or chiropractor. If any of those healthcare professionals have a suspicion of axial spondyloarthritis, they're referred to a rheumatologist who makes a diagnosis where appropriate. Nonetheless, we know that there's a significant delay to diagnosis, and we have to, as a community, do better to reduce that delay to diagnosis, because as I show you, the impact that delay of diagnosis has on someone is really quite great. So what is the delay in diagnosis? This was a study that a colleague of mine in the UK and I did, looking at 1,200 patients with axial spondyloarthritis. And it didn't matter whether we looked at our cohort entirely or just in the 5 years at the time of the publication, the delay in diagnosis was around 8.5 years. As I said, the impact is huge. So in this study that was done back in 2009, the authors separated patients with axial spondyloarthritis into those who had an early diagnosis, less than 6 years, which was the mean, and more than 6 years. And you can see that if you've had a late diagnosis, the disease activity score, the BASDA, is significantly higher. The physical function score, the BAS-Phi, is significantly worse. And the restriction in mobility, the BAS-Mi score, is also significantly worse. What we and many others have shown is also there's a great impact on work disability. So for every year there's a delay in diagnosis, the chance of being work disabled increases by 6.6%. Again, a big reason to diagnose this condition early on. The National Axial Spondyloarthritis Society, based in the UK, have done a number of analyses exploring this delay further. This first analysis shows you the number of visits each person has to go through before they get a diagnosis. And you can see 65 people visited their GP 5 to 10 times, and 67 people visited their physiotherapist 5 to 10 times before they got a diagnosis. If we look at the pathway as a whole, what you see here is that 31% of people waiting a mean of 2.49 years from the time they have symptoms to the time they go and see their GP, and then 4.33 years, so the significant delay from the GP appointment to getting a rheumatology appointment. So a lot of the delay happens when someone's wondering if the back pain is due to overdoing it at work or their sports or some kind of muscle strain, and then where a primary care healthcare professional may not have detailed knowledge about this condition. The second thing we've seen in the UK is that if a hospital has a specialist rheumatology axial spondyloarthritis service, the delay is significantly shorter. So here, a mean of 7.2 years if you've got a specialist service, and a mean of 10 years if you don't. So that specialist service definitely makes a difference. And then finally, we know there's a gender gap. We know that women take longer to get diagnosed with axial spondyloarthritis. But when we looked at this data, we were quite surprised that if you look at the first room appointment to diagnosis, a man takes a mean of 0.59 years to get a diagnosis, where a woman will take 1.25 years. So, as I said, there is an issue potentially in primary care, but in secondary care, in rheumatology services, there is also work to be done. So why do we have a problem with delayed diagnosis in axial spondyloarthritis? I've touched on the fact that there's poor healthcare physician awareness. There are these common myths around that people think AS is a male-only disease. Our blood tests are not massively useful in this condition because we know, for example, 10% of people with axial spondyloarthritis will be HLA-B27 negative, and an inflammation blood test called C-reactive protein, or CRP, is only raised in 40% of AxSpA patients. We have a lack of diagnostic criteria. We have what we call classification criteria, but these are only intended to be used to ensure we're selecting the right patients for clinical trials, not for diagnosis. I will come on slightly later in the talk to the difficulties we have with imaging. And then I'll show you as well that actually axial spondyloarthritis forms a really minor subset of patients who present with inflammatory back pain. What has changed with this condition is that the advent of MRI has enabled earlier diagnosis. Prior to the availability of MRI, all we had were X-rays. And what this chart shows you is that it takes time for those X-rays to become abnormal. Again, typically 8 to 10 years. What we're seeing here are a patient's sacroiliac joints showing sacroiliitis. A proportion of patients with sacroiliitis will get spinal involvement. And here what we're seeing are bridging syndesmophytes, or bone formation between the vertebral bodies. So this is what we always knew as the radiographic stage, meaning X-rays show damage. And this is what we always knew as ankylosing spondylitis. MRIs have now become available, and they show, or can show, the disease at an earlier time point. And so this is what we've called non-radiographic, meaning not showing on X-rays, axial spondyloarthritis. And the entire umbrella is now known as axial spondyloarthritis. So I made the point earlier that we don't have diagnostic criteria, but we have classification criteria. But essentially what I'm trying to show here is we use these features appropriately to help us make a diagnosis. And I'll talk you through some of these features in more detail on subsequent slides. The other point I wanted to make is when we think about what we call the extra musculoskeletal manifestations of the disease, so these are uveitis, inflammation affecting the eye, psoriasis, inflammation affecting the skin, typically seen in the scalp, elbows, knees, natal cleft, and inflammatory bowel disease, so Crohn's disease and ulcerative colitis, that adds support to the diagnosis of axial spondyloarthritis. And the point I'm trying to make with this slide is that these features do not occur in a specific definitive order. You can have someone who gets uveitis first, then gets inflammatory bowel disease, then gets diagnosed with axial spondyloarthritis. Or you can have someone who's diagnosed with axial spondyloarthritis and will subsequently be diagnosed with the other conditions I mentioned. So look, back pain is complex, as I said. Axial spondyloarthritis is one reason for back pain, but back pain can also be experienced if someone has degenerative change in their spine. So if a disc is worn, if the facet joints are worn, if the nerves are being pinched, these are all mechanical degenerative problems that can cause back pain. Again, very rarely, some people may experience a fracture in the spine after an episode of trauma, and that can present with severe back pain, which again needs to be reasoned out and diagnosed separately. And then just to say, someone with ankylosing spondylitis obviously will get back pain, but even with more established disease, the back pain is ongoing. So the first thing to say is we don't want to frighten everyone to make everyone think, well, I've got back pain, I must have axial spondyloarthritis. We have to separate what we call chronic and acute back pain. So typically, chronic back pain is someone who's had back pain for 3 months or more. Most disc problems, acute back pain episodes usually settle within 6 to 8 weeks. But if someone has back pain more than 3 months, we call this chronic back pain. And axial spondyloarthritis back pain is inflammatory versus mechanical. And you need to have inflammatory back pain as the key feature that then draws you towards the next step. So what do I mean by those differences? Again, just to remind you that in this study, which looked at 505 patients, in the total population of back pain patients, 14.9% fulfilled these inflammatory back pain criteria. So the proportion of people who experience inflammatory back pain is significantly smaller in the entire group of back pain patients that are seen. And really, this is one of the key slides in trying to separate what is inflammatory back pain versus mechanical back pain. Typically, people who get inflammatory back pain, the back pain starts when they're young, in their 20s or 30s. The back pain is likely to come on gradually. It's never, I woke up one morning and I had this severe pain. It's likely to come on slowly. And then this key feature is that inflammatory back pain tends to like movement. So if I said to someone, if I gave you the option of sitting in a chair for 3 hours and relaxing and not moving, is that okay? Or would you like to move around every half an hour or so, have a few steps and come back and sit down? And usually if someone has axial spondyloarthritis, they want that level of movement. It's not about running a marathon. It's about being able to move to relieve the back pain. And similarly, it will not improve with rest. Another key feature of this condition is that it can make people wake up at night. So this is not about having difficulty getting off to sleep, but once you sleep, you then wake up at 2 o'clock, 3 o'clock, 4 o'clock in the morning with this back pain. And finally, typically stiffness in the morning lasts over half an hour. With mechanical back pain, people can get stiff for 15, 20 minutes in the morning. But if the stiffness is lasting over half an hour or an hour, that can be consistent with inflammatory back pain. So I touched on the extramuscular skeletal manifestations, which are predominantly uveitis that we see here, psoriasis or Crohn's disease. Even though axial spondyloarthritis is predominantly affecting the spine, you can get other joints involved, so things like a swollen knee, the Achilles tendon at the back of the heel becoming inflamed. These are all features that can be associated with axial spondyloarthritis. There's a strong family disposition. So if someone's father had axial spondyloarthritis or mother had axial spondyloarthritis, that's very relevant for us to take into note. So when I'm making a diagnosis of axial spondyloarthritis, I'm putting everything that you see on this slide, what's present, what's not present, into the equation for me to make a diagnosis. I touched on earlier the fact that in the old days, men were supposed to have AS alone, but actually in more recent studies, we're seeing, particularly in that early non-radiographic axial SPA population, the balance is probably slightly more leaning towards women, but I would like to say it's probably more 50-50. But I would also say that men tend to get the more progressive radiographic damage version of axial spondyloarthritis. I'm going to be brief here for interest of time, but just to say that when we're making diagnosis of axial spondyloarthritis, the two main forms of imaging we'll use are X-rays or MRIs. So here we're looking at the joints over the buttock area, and these are the sacroiliac joints. These are normal, clear, crisp margins with that black bit in the middle being a sacroiliac joint. Whereas here you can see there's no black bit in the middle. This is someone with advanced axial spondyloarthritis where the sacroiliac joints are fused. This is somewhere in between. You can still see some of the black joint bit in the middle, but the margins are very irregular. There's whiteness around the margin, and this is what we call sacroiliitis, which is consistent with axial spondyloarthritis. In the spine, we can see bits of new bone that are bridging. So these are bridging syndesmophytes. Again, only really seen in advanced axial spondyloarthritis, but to be honest, we're seeing less and less of that these days. With MRI scans, the main point I'd like to get across is that you have to have a specific type of MRI to get a diagnosis of axial spondyloarthritis. Many of our orthopedic colleagues are doing MRI scans to look for disc prolapse, to look and see if nerves are being pinched. But by doing what we call stir sequences, we can see inflammation on that scan. And if you're ever going to have an assessment for axial spondyloarthritis, you need to make sure you have had these sequences done on your MRI. Now, again, I'm not here to teach everyone to become a radiologist, but I want to show you some examples of what we're looking for. These, again, are your sacroiliac joints over the buttock areas. The black bit is the space. Here, this whiteness is inflammation. And if this person was to have an X-ray, you won't see any changes. The MRI scan is showing you this whiteness, which is inflammation. But what happens is sometimes the inflammation may not be very extensive or maybe quite localized. And so it can be difficult for a radiologist to be sure if it's definitely axial spondyloarthritis or something else. And I'll come back to that point in a second. In the spine, much like in the sacroiliac joints, once again, you see inflammation. These white areas, very well demarcated and pronounced, are consistent with someone who's got axial spondyloarthritis. Again, just to remind ourselves about the spectrum of severity, which can make diagnosis difficult. Here on the right, clear areas of this whiteness, which is inflammation in and around both sacroiliac joints. On this MRI on the left, again, some areas of whiteness, which may or may not be inflammation. So when you're going and seeing someone to get a diagnosis, if they're discussing with you that your MRI scans are not that clear cut, this is what they're trying to get at. The other challenge with MRI scans is, whilst I've shown you very good examples for axial spondyloarthritis, sadly, they're not specific always for axial spondyloarthritis. Studies like this have shown that even 23.4% of healthy participants who have no back pain but are going along for an MRI show signs of these potential inflammation changes on their sacroiliac joints. People who stress their sacroiliac joints a lot, if you run a lot, do lots of exercises, that can give you the same appearance. And for someone who's given birth within the last 6 months, an MRI done in that time, again, might show you changes in the sacroiliac joints that are more to do with having been pregnant and given birth than actually axial spondyloarthritis. So the key take-home message here is that a positive scan does not necessarily equal axial spondyloarthritis, but needs to be put into the context of the entire clinical picture. The second point I want to make around MRI scans is that just because the first scan is normal, it doesn't mean you shouldn't have a second scan. And this is particularly true if you are positive for the blood test gene marker HLA-B27. So here, if you had a normal first scan and another scan was repeated at 2 years, if you were HLA-B27 positive, there was around a 30% chance that the second scan would be abnormal. So B27 positive, first scan normal, it is for me worth having a second scan. And the final point around MRIs is it does matter if you have a scan and you're on anti-inflammatories. For the interest of time, I'm not going to go into this study in huge detail, but essentially what it showed is that if you don't stop your anti-inflammatories for a week or two before your MRI scan, you will miss the bone marrow edema that goes with axial spondyloarthritis in 1 in 5 people. So hugely crucial for anyone who's going for a diagnostic MRI scan, stop those anti-inflammatories for a week or two before. I've put this in as a broad pathway of what we follow, but I really want to focus on the points on the right. We have to be cautious around using classification criteria for diagnosis. As I said earlier, I'm trying to pull in every feature, the extramusculoskeletal manifestations, the blood tests, the family history, the MRI scans, when I'm making a diagnosis. What job you do and your exercise regime are important to get across to your healthcare professional because that will help them make a decision. Make sure you don't take anti-inflammatories for a week before the scan, and then consider having a repeat scan, particularly if you're HLA-B27 positive. So when should you see a rheumatologist? If your back pain has been present over 3 months, I think that's a really good starting point. If your back pain are matching the inflammatory back pain criteria, stiffness in the morning over half an hour, better with activity, worse with rest, waking up in the second half of the night, 2 or 3 in the morning. All of these features are factors that help you decide whether it's inflammatory or not. Another couple of top tips, and these are more from my personal experience. Often people are told that, look, your back pain is sciatica, but sciatica pain goes from the back right down into your feet. And occasionally people with axial spondyloarthritis will get this buttock pain that feels like sciatica, but the pain never goes further than the thigh or the knee. I think another key feature with axial spondyloarthritis is this concept of a flare pattern. Typically, people will have a bad 2 weeks or bad 4 weeks, and then they may not experience any symptoms again for 3 months. This kind of flare pattern can be quite typically seen in axial spondyloarthritis. If an ophthalmologist has diagnosed you with having uveitis, A dermatologist or GP has diagnosed you with having psoriasis. A gastroenterologist has diagnosed you as having Crohn's disease or ulcerative colitis, and you've had back pain for over 3 months. Please fill in the inflammatory back pain questionnaire and go along to your primary care healthcare professional and say, could I have axial spondyloarthritis? I say here, challenge the clinician, but obviously politely, but challenge the clinician who says you can't have AXPAR because your inflammatory markers, the CRP is normal, or because you're HLA-B27 negative, or because you're a woman. These are questions to say to healthcare professionals, but I've actually read that, you can have AXPAR if the blood tests are normal. What do you think about that? I think it's worth just having the conversation. So to summarize this short talk, there is unfortunately still a big delay to diagnosis in axial spondyloarthritis. What I've also tried to show you that from the rheumatologist side, it can be a complex diagnosis to make. The MRI challenges, how severe is the MRI? It's not showing any changes. The blood tests are normal. It's complex. Interpreting those MRIs and X-rays I've shown you remains challenging, and one day, I guess, with AI and machine learning, it may become easier. And we are now, through newer technologies, to help primary healthcare professionals trying to improve that delay to diagnosis or the time to diagnosis and really shorten it down from the 9 years that we're now experiencing. So with that, I'll thank you and hope you find my talk helpful. Many thanks.
Hello, friends. I'm Dr. Abhijit Danbe, Associate Professor of Medicine and Director of Spondyloarthritis Program at Yale School of Medicine. Today, I'm going to speak about overview of axial spondyloarthritis. I would like to thank SAA for providing me the opportunity to speak at HealthEd Livestream. Today, we are going to discuss the clinical manifestations of axial spondyloarthritis, discuss the diagnostic approach, learn about the treatment options, and also review the comorbidities and complications. So, spondyloarthritis is a group of conditions. These are interrelated conditions that share similar genetic and pathologic features. For the clinical relevance, we like to think about spondyloarthritis as two big groups: axial and peripheral. Axial spondyloarthritis usually affects the spine and sacroiliac joints. In axial spondyloarthritis, we have ankylosing spondylitis, that's late stage, and non-radiographic axial spondyloarthritis, that is the early stage of the disease. In the peripheral group, we have psoriatic arthritis, IBD, that's inflammatory bowel disease related arthritis, reactive arthritis, and undifferentiated spondyloarthritis. So, what is axial spondyloarthritis? It's an immune mediated chronic inflammatory condition that can involve axial skeleton as well as peripheral skeleton. And not only that, it can also involve eyes, intestines, and the skin. This condition mainly affects individuals in their third and fourth decade and frequently leads to significant pain, loss of function, work disability, and impaired quality of life. Patients can present in various ways, and the progression is not also similar in all the patients. Some patients may progress, some patients may not, as we will see in the next slides. Why should we care about this condition? Because not every patient's back pain is mechanical, like from the disc disease or scoliosis or facet arthritis. This condition is much more common than we think. It is frequently missed by all kinds of specialists, including internal medicine doctors. As in other inflammatory conditions, axial spondyloarthritis can be associated with high risk of hypertension, heart disease, stroke, etc. And most importantly, nowadays we have great treatment options for axial spondyloarthritis. And if we can identify this early and treat it promptly, we can avoid the future progression or we can slow the progression of the disease. What are typical clinical features for axial spondyloarthritis? We can think about them as musculoskeletal manifestations and non-musculoskeletal manifestations. Among the musculoskeletal manifestations, we have inflammatory back pain, which is the most common symptom of axial spondyloarthritis. And patients can also get arthritis in their extremity joints, dactylitis or sausage digit, enthesitis or tendon inflammation, and anterior chest wall pain is a frequent clinical manifestation of axial spondyloarthritis. Among the non-musculoskeletal features, we have uveitis, which is eye inflammation, inflammatory bowel disease like Crohn's disease or ulcerative colitis, and psoriasis. As a group, spondyloarthritis patients tend to have strong association with the gene HLA-B27. There tends to be a familial clustering of the conditions. As compared to rheumatoid arthritis, where there is bone destruction, in spondyloarthritis, you can also see bone formation that is called osteoproliferation. As I told you, the most common symptom for axial spondyloarthritis is inflammatory back pain. And as my colleague Dr. Raj Sen Gupta might have told you or will tell you, inflammatory back pain has to be differentiated from mechanical back pain. And there are some peculiar features that we'll go through in a brief here. Inflammatory back pain typically starts before age of 45, lasts for more than 3 months, usually starts gradually. There is morning stiffness for more than 30 minutes or so. The back pain improves with exercise and does not improve with the rest. Sometimes it can wake patients up from their sleep and they have to stretch to get better. And typically it responds well to NSAIDs. Some patients can have alternating buttock pain. Peripheral arthritis typically involves lower extremity joints. It is acute, intermittent, and usually involves 3 to 4 joints. About 30 to 40% patients with axial spondyloarthritis develop peripheral arthritis. Enthesitis is a common symptom of these patients. The enthesis is the site of insertion of ligaments, tendons, and joint capsule to the bone. So there is inflammation at the ends of the tendons. This is early and relatively specific feature of spondyloarthritis. Common sites for enthesitis are Achilles tendon, the plantar fascia insertion, that's plantar fasciitis, lateral epicondyle, that's tennis elbow, and sometimes belt line pain when there is enthesitis of iliac crest. Dactylitis or sausage digit happens because of diffuse swelling of the flexor tendon, the tendon sheaths, and the soft tissues. It can also involve joints. Uveitis is by far the most common non-muscular skeletal manifestation of axial spondyloarthritis. It is caused because of inflammation of the anterior chamber of the eye or iris area. That's why it's also called iritis. It's typically one-sided, acute, anterior, and it gets better on its own or with the help of steroid eye drops. Usually patients do not develop visual impairment from acute anterior uveitis. And we think that about 30% patients with axial spondyloarthritis develop acute anterior uveitis during their lifetime. Psoriasis is common in general population. About 1 to 3% patients in the common population get psoriasis, but in patients with axial spondyloarthritis, the prevalence of psoriasis is as high as 10%. You're going to take a look at the scalp, gluteal cleft, nails, both fingernails and toenails, for occult psoriasis or hidden psoriasis. Inflammatory bowel disease also has a close connection with axial spondyloarthritis, such that if we do blind colonoscopy biopsy of consecutive 100 patients with axial spondyloarthritis, about 50 to 60% will have asymptomatic or subclinical inflammation, and about 7% of them will develop frank inflammatory bowel disease. And if you look at patients with inflammatory bowel disease, about 20% of them will have spondyloarthritis. So there is a close connection between problems with the gut microbiome and development of arthritis or spondyloarthritis. This condition, axial spondyloarthritis, is closely linked with the HLA-B27. So not everyone with positive HLA-B27 is going to develop axial spondyloarthritis, but among the patients with axial spondyloarthritis, you are going to find a large prevalence of positive HLA-B27. So in Caucasians, B27 is about 6 to 9%, and in African Americans and Hispanics, it's about 4 to 5%. So among the patients with axial spondyloarthritis or ankylosing spondylitis in particular, 90% of them will have positive HLA-B27. But if you look at 100 people with positive HLA-B27, only 5% will develop ankylosing spondylitis. Such is the relationship. And about 20% relatives of patients with axial SPA who have positive HLA-B27 will develop one of the spondyloarthritis conditions. Let's look at the classification and epidemiology of this condition, like how common this is, how the progression happens, etc. So if you remember the second slide, I showed you that there is axial group and a peripheral group. Among the axial group, you have early stage, that's non-radiographic axial SPA, and late stage, that's radiographic, or other words, ankylosing spondylitis. So ankylosing spondylitis, by definition, patients have damage that shows up on X-ray of their SI joints. So they have to have grade 2 bilateral or grade 3 unilateral sacroiliitis on X-ray. Ankylosing spondylitis is slightly more common in men than women, and it can cause more functional limitation because of the radiographic progression that happens. Among the non-radiographic axial SPA, there may be completely normal or only slightly abnormal X-ray, but they can have inflammation that shows up on the MRI of the pelvis to look for sacroiliitis. And That's how the MRI is important in patients who have early stage of axial SPA. The non-radiographic disease tends to be equal among men and women. If we look at the pain level or functional limitation level of the patients with both early stage and late stage, both these groups tend to suffer equally. That is why we consider this as one group when it comes to the treatment aspects. We usually treat these patients as one group and not change the treatment based on whether they have non-radiographic disease versus ankylosing spondylitis. So not all patients who start off with inflammatory back pain are going to develop frank ankylosing spondylitis. We think that only 15% patients with inflammatory back pain will eventually develop axial SPA. Some of them will remain at the non-radiographic stage. About 20 to 30% patients with non-radiographic disease will eventually develop ankylosing spondylitis. But also within the ankylosing spondylitis group, not everyone is going to develop fused SI joints and bamboo spine. So that's one of the common questions that we get from the patients. So the bottom line is the progression of this condition is one, slow, second, it is quite variable. And so that's why we cannot really predict who will progress and who will not progress, although there are some predictors of progression. There is no diagnostic criteria as such for this condition. There are classification criteria. One of them is ASA's classification criteria that was published in 2009. These criteria is more important for clinical research and clinical trial, and we do not use that to make the diagnosis in the clinical practice. We all think that rheumatoid arthritis is the most common inflammatory arthritis, whereas the fact is the most common inflammatory arthritis in the United States is gout. But when it comes to axial SPA may be much more common than rheumatoid arthritis. But when we look at our clinic schedules, we see very few patients with axial spondyloarthritis and so many patients with rheumatoid arthritis. And what we think is it's actually tip of the iceberg that we actually see in the clinical practice. So many patients with axial spondyloarthritis are diagnosed late or they are not diagnosed at all. There is average delay in diagnosis between symptom onset and diagnosis of about 6 to 9 years. And this has been the steady statistic for last several decades. So we know that we need to do better when it comes to the early diagnosis of axial SPA. And this delayed diagnosis can result in many adverse outcomes that can result in worse disease activity, worse physical function, more radiographic progression, poor quality of life, can affect patients in a different way, like there is more burden of mental health problems in these patients, there is more work disability, and of course, high healthcare costs. So there are many advantages for us to be able to diagnose this condition at earlier stage. The reasons for delay in diagnosis are several. One of the important ones is poor awareness about this condition and poor knowledge among healthcare providers about axial SPA. It is possible to get it's possible to get axial SPA with negative HLA-B27 gene. So that is one of the factors. There are some sex differences, racial disparities. There is lack of consistent referral recommendations, like which patient should be referred to rheumatology for evaluation. There are no diagnostic criteria, and there are some patient factors that may contribute to delayed diagnosis of axial SPA. So how do we make the diagnosis of axial SPA? Usually we use pattern recognition, and the gold standard for diagnosis of axial SPA is clinician's judgment. What we do is we take thorough history from the patient about the quality of their back pain, the characteristics of their back pain. We ask them about other symptoms involving the joints or tendons. We get family history. We ask about the non-musculoskeletal symptoms for the condition. We get blood work, mainly CRP, to look for inflammation, and the HLA-B27. Imaging plays important role. We try to look for the sacroiliac joint damage on the X-ray, and we look for damage as well as active inflammation on the MRI. And eventually we decide with the help of all these factors whether the patient has axial spondyloarthritis or not. As I told you, X-ray and MRI of the sacroiliac joint and the spine are very important to arrive at the accurate diagnosis. What you are looking at here is on the top left, you are seeing X-ray of the lumbar spine, that is showing bamboo spine or fusion. Those arrows indicate that there is fusion between the vertebral bodies. The second image is showing fusion at the cervical spine. Bottom two images, you can see the MRI changes, active inflammation, as well as the structural changes in the form of erosions. And on the right hand, you can see the bottom image shows that there is no SI joint left. The both SI joints have fused with each other. And the image C shows that there is severely damaged sacroiliac joint. So we call this radiographic sacroiliitis. And this is hallmark for diagnosis of axial spondyloarthritis. The question is, if we want to identify all the patients with axial spondyloarthritis, can we refer them all to rheumatology? And the answer is no, because among the general population, about 20% of individuals have chronic back pain. Only 5% of the back pain patients have axial spondyloarthritis. And as rheumatologists, we will be overwhelmed if we start seeing all the back pain patients. So there is more and more need for developing screening and referral strategies or some kind of a filter to decide which patient should be referred to rheumatology for further evaluation. There has been good amount of research done in this area, and there have been several single center, multi-center, as well as international studies. And they show us consistently that when we use one type of referral strategy, the yield for these strategies that comes out that about 35 to 45% patients ultimately get diagnosed with axial spondyloarthritis, which is very good. And one of the proposed strategy is, if there is a patient with chronic back pain that started before age of 45, if they have either inflammatory back pain or positive HLA-B27 or sacroiliitis on imaging, then they should be referred to rheumatology. And if we use this strategy, 1 out of 3 patients will turn out to have this condition. But if you look at this, we will need to get B27, that's a blood test, and X-ray or MRI, which are expensive tests. So this strategy may not be applicable for mass screening for a public health issue like a back pain. So we need more simpler screening, survey, or referral strategies for axial spondyloarthritis diagnosis. We have developed a simple practical screening survey, which is to be filled out by the patients themselves. So we don't really need a particular healthcare provider to administer the survey. There are 8 questions in this screening survey, which are easily answerable as yes or no. At the end of this, this survey calculator will give you the probability of possible axial SPA. This is not a diagnostic tool. This is a screening tool to identify the right patients who should be referred to rheumatologists, either self-referral or the referral through the primary care providers. Another initiative that we have undertaken in United States and Canada, or in North America, I should say, is on behalf of Spondyloarthritis Research and Treatment Network, we have developed referral recommendations to decide which patients with back pain should be referred to rheumatology. And we have developed a nice scoring algorithm. Although this strategy is supposed to be administered by a primary care physician or a healthcare provider, and this is not meant for self-referral. Talking about the treatment of this condition, as you might know, there are 2 pillars of the treatment for axial spondyloarthritis. One is the lifestyle modifications, so smoking cessation, regular exercises, physical therapy, weight control, all have a very important role. At the same time, medications are also very important. As I said, these are the great days for axial spondyloarthritis or psoriatic arthritis and many other autoimmune rheumatic diseases. We have more and more effective medications available. For axial spondyloarthritis, we had NSAIDs and TNF blockers only, but now we have interleukin 17 blockers as well as JAK inhibitors in our armamentarium. So we are able to treat these patients effectively if we can diagnose them on time and with accuracy. In general, we start with non-steroidal anti-inflammatory drugs, and if the patient do not respond or if they cannot tolerate, then we may start them on TNF blockers or interleukin 17 blockers. JAK blockers or JAK inhibitors are usually spared as the third line therapy at this time, although that may change in the next few years. There are several comorbid conditions that coexist with axial SPA patients, and that include hypertension, cardiovascular disease, both stroke as well as heart attacks, depression. Osteoporosis is quite common. So on one hand, these patients have more new bone formation, but the bone that gets formed is brittle, so they're at risk of fractures. Restrictive lung disease or interstitial lung disease is also possible comorbid condition, and about 1% patients can get kidney disease that can include kidney stones as well as IgA nephropathy, which is a rare complication. So as I told you, spinal fracture is one of the devastating complications from osteoporosis that coexist with axial SPA patients. Some of them can have heart issues like aortic valve incompetence or conduction block. Rarely patients can get amyloidosis. When there is pulmonary or lung involvement, it tends to cause fibrosis at the upper lobes, and rarely patients can get neurological complications called cauda equina syndrome. When we take care of the patient with axial spondyloarthritis, we really like to involve all related specialists as well as primary care doctors, and this includes ophthalmology, gastroenterologists, dermatology, physical therapist, and pain management. This is a multidisciplinary approach that actually benefits the patients the most. In conclusion, it is important to recognize the disease early, find the appropriate patients for referral to rheumatology. It is very important to diagnose axial spondyloarthritis at early stage so that we can start them on appropriate therapy and avoid long-term outcomes. Remember, both the non-radiographic stage as well as late stage ankylosing spondylitis symptoms are similar. These patients suffer equally and we treat them as one disease entity. I hope this presentation sheds more light about the various clinical manifestations and the treatment approaches to the patients with axial spondyloarthritis. Again, I would like to thank SAA for providing us with this opportunity, and I look forward to participating with you in the live Q&A session.
Hi, everyone. My name is Chuck Melindy, and my company is named Disruptive Dialogue, and the goal is to help fix healthcare in the U.S. Before we get started today, speaking on advocacy and helping patients to have their voices heard, I'd like to thank the Spondylitis Association of America for allowing me to speak at their HealthEd Livestream event. And I look forward to presenting this to you and then a nice Q&A afterwards. My background is 35 years in the healthcare industry. I have done work, obviously, in the US. I also had 2 years in Europe, handling 17 countries, so I understand their healthcare systems as well. I do have an expertise in drug price negotiations with insurers and their PBMs, as well as advocacy and policy work in the legislative space, working with physicians, patients, and employers around trying to impact healthcare reform. The last 25 years of my career was with Johnson & Johnson, and I left them in January to start a podcast so that I could start to inform the American people with what really is happening in the healthcare industry behind the scenes. When you work for a large corporation, you are limited to what you can say because you're speaking for them. So this allows me to speak to everything that I know. And so that's been my goal for the last 8 or 9 months, is to have a podcast, a newsletter, as well as working with benefit consultants to help employers when choosing the right type of health insurance for their teams. So what we're going to focus on today is advocacy. And as many of you may or may not know, advocacy is the act of supporting, promoting, or speaking up for a cause, a policy, or a group of people. The goal to enact positive change. A lot of people may not know what it is or may be nervous about doing advocacy, but what you don't realize is we do this every day. We all have tried to get our kids into a certain school or a certain class or have a certain teacher. That's advocacy. We've tried to help a loved one or a friend get into a certain physician's office or to a different hospital room. Same thing. That is advocacy. And some of you may have gone to a school board meeting or a chamber of commerce meeting and spoke on issues that you believed in. All of these are different types of advocacy, basically speaking, pleading, or arguing in favor of a position or a cause that you believe in. And the reason that it's needed is because sometimes people who need to make change aren't aware of issues or concerns that are out there, or there may be people who are unable to advocate for themselves, and so that you can do that for them. So what does effective advocacy look like? Basically, there's 3 main pillars: educating, empowering, and mobilizing. Around education, it's not just educating people who have influence or organizations who have influence that you're trying to convince, but also educating yourself. There's always research to be done. Once you're able to educate individuals or organizations, then you can help them be empowered to make change. And lastly, mobilizing. Just because you've educated someone and you've asked them for change, how are you going to turn that into action? So let's break this down a little bit more. So one thing that is probably as crucial as anything is advocating for something that you believe in. When you have a passion for something, you have conviction. And so I want to give you a real quick example of something that I think exemplifies this tremendously. Probably in my 2nd or 3rd podcast earlier in the year, I was talking to an independent pharmacist, and he was my guest on my show. And he told me an incredible story about how their independent pharmacy was kicked out of an insurer's network. Well, a lot of people used to go to this independent pharmacy, and some of them went there for like compounding of specialty medications. That is very complicated. There's a lot of services around that. Well, 2 of the patients that used to see them, their insurance company had kicked the independent pharmacy out of network. And they were like, wait a minute, this is not working for us. You are a trusted provider. You're local to where we live. We trust you. You provide us with the knowledge that we need. And so these two individuals were actually pilots for a large airline. They went to their HR department and basically shared with the HR department the impact that this small independent pharmacy being kicked out of their network would have on their lives. And that employer's HR department then went to an insurance company and they told the insurance company, hey, we're paying you for benefits. There's no reason for you to kick this independent pharmacy out of network. You need to change that. That advocacy by just those two employees for a large employer actually made a change in policy that impacted all the employees in that organization. And they put that independent pharmacy and other independent pharmacies back in their network. So this is an example. It doesn't matter if you're David versus Goliath, if you're going to fight the huge conglomerates, a huge hospital system. If you believe in something, you have conviction, and you can tell your story, you can make a difference. So regardless of what your issue is, there are certain aspects of advocacy that will always remain. And you always want to think of, what is my objective? And so we'll go around this circle. So real quick, your objective may be to activate legislators on policy issues. It may be just to heighten awareness in your community. You may just be trying to identify other stakeholders with a shared view. Once you find those stakeholders, your goal then is to inform them. And lastly, to influence policymakers' opinions. So these are some key pillars that you want to always keep in mind when you're looking at what objectives do I have along this advocacy journey. So how will we be effective in enacting change? So first off, and I think it's key, is establishing your relevance. And that is going to come in many forms. If you're talking to legislators, if you're in their district or their community, you're going to have relevance. If you're going to a physician's practice and you are one of their patients, you're going to have relevance. But also you need to be informed about what you're talking about and be able to tell a story. So being able to clearly explain the problem through a story is key in advocacy, and we're going to expand on that in a few moments. You want to be able to provide context or ability to compare what you're trying to talk about to other things clearly. You want to be able to explain and simplify the effects of not only if they make this change, but if they don't make that change. Sometimes inaction is worse than taking an action. And then don't leave it up that, okay, you've come, you've told your story, you've convinced them it's important. You need to have some recommendations that are actionable for them. Let me tell you what, everyone you're going to go to that you're going to try and get them to do something, we're all very busy. The last thing they want is, okay, you came in, you told them a problem, you complained, you told them why it's an issue, but now you're going to make them put together a plan of action? No, you need to have that plan of action when you walk in there. And then lastly, more than likely, they're doing you a favor and they're going to help you or a loved one. You need to follow up with thank you and next steps. Show them gratitude, tell them how much it means. Always end on that. So there are so many ways to advocate. I'm going to go through a couple, but there's a lot more, but this is a good start. So what I used to do is I used to work with members of Congress or state legislators. And so there are different ways that you can advocate. Now, without a doubt, any communication is good. It's better than no communication. But as always, there are some types of communication that are better than others. And I can tell you right now, you can email or you can write letters to your legislators, but phone calls are so much more effective. I can tell you point blank, I've heard it from legislators both on a federal and a state level. They will walk in to their staffer's office and they'll say, hey, what's the hot news today? And the staffers will say, you know what, we got 15 calls about this issue, or we got 2 calls about this. But the more calls that come in and the opportunity you have to speak to a legislator or their staff is huge. Now, one thing that we're going to touch on is, well, I don't know. It's going to be really hard to get a hold of my elected official. I don't even know where to go. We're going to walk through that, but I already put in this slide. You can see how to reach your legislator. If you type in this email if you type this into your website browser, you will have the website pop up that will help you get to your legislators. But we're going to walk through a couple of slides that will show you how to do that. Now, that's on a congressional or federal level. But let's talk about local or state representatives that are in your district. Hey, you may not want to attack this on a federal level. You may want to, you know what, I want to take care of my state. I want to take care of my community. You can still work with them. Once again, I'll walk you through how to get to them. But at the end of the day, it is no less important to go to your state officials to pass legislation as it is to your federal officials. And quite often in healthcare, what we have found over the last 10 to 15 years, a lot more change happens at the state level than at the federal level. And not just that, when the feds start to see multiple states pass legislation, this gives them a signal that this is bigger than a local or regional issue. There are certain pieces of legislation that we have 23, 25, 30 states have passed laws on a certain type of issue or cause. That gets your Congress, your different congressional leaders interested, involved, and gets their attention, and then they take it up on a federal level. So those are different kinds of representatives. You can also go to social media, whether it's Facebook, Twitter, Blue Sky, TikTok, Instagram, you name it. This is another way that you can advocate, that you can get a message out or a cause or an issue out to your community. And if you don't feel comfortable using these type of apps, or you don't know how to do it, go to someone who's in your family or friends who's younger and they're comfortable with these apps. Ask them how to do it. Lastly, you can go to your local television stations, local newspapers. Look, I've published stuff in USA Today and some op-eds in the Wall Street Journal, but it's very hard to get into the papers on a national level. But your local newspapers, your local TV stations, they want to know what's going on in my community. And that is a place that you can also go to and that you can enact change, especially if you feel like you're hitting a brick wall with your legislators or others. But we are going to go through a couple of other resources. But bottom line is, there are so many organizations that have websites to give you additional ideas and tips on how to be effective when you're advocating and different ways to do it. Like I said, there's lots of tools available out there. I know that the Spondylitis Association of America, who I'm speaking for today, they have spondylitis.org. And if you go to their advocacy page, it's awesome. They've got a lot of great tools. I'm using one of my pages from Disruptive Dialogue, my website, because I'm very familiar with it. And you can see, like, you could go to the website and there's these different things: how to be an advocate, share your story, actions for employers, contact your legislators. You just click on one of those buttons, and this will be very familiar to other websites. It'll take you to the tools that you need. There are other organizations. You can go to the AMA, you can go to CSRO. There are just, you name it. You could go to the, I like to say, go to the Google. You go to the Google and just basically say, I'm a spondylitis arthritis patient, and I would like to have the name of organizations that will advocate on behalf of a certain condition. And those will pop up. Go to those resources and check them out. But at the end of the day, what I have learned over the years is stories are the key to everything. Look, our legislators, you can see it in the media, whether it's social media, the newspaper, TVs, there are healthcare statistics everywhere. And as someone who graduated an accounting degree, statistics can be manipulated to say what you want. But legislators and the media are moved by real life stories. They need to hear your experience or someone you know and the story that pertains to their issue. And what makes a good story? Being able to paint a picture that someone can relate to. How did everything start? And how did it end? Or where is it currently at? And what was that journey along the way? What did that look like? And you also need to make sure that your story starts and ends with 1 or 2 details that you want them to remember. Look, if you want to know how impactful it is, just think about all the different State of the Union addresses that presidents for the last 20, 30 years have done. Almost every single time, if they really want to make a point and get people to agree with their position, there's almost always a visitor up in the gallery that they will point to. They'll tell their story and they'll tell why it's important for what they want. Being able to help people, legislators, the media, you name it, being able to help them relate to why it's important and bring something emotional that ties to that story is huge. On my website, like others, okay, you may say, well, I don't even know how to tell a story. I'm not good at storytelling. There are resources to help you. So the power, like this says, the power of sharing your story, it is nothing's more compelling than a firsthand account of the challenges faced within the healthcare system. These personal stories enable you to humanize complex issues. There is so much evidence that this helps to influence policymakers and drive reform for change. This slide, as well as other resources you'll find on the web, will be able to show you how to highlight different things like medical debt, insurance denials, medical switching, copay assistance, and other issues that we all run across every day in our healthcare system. So I told you I'd give you a couple screenshots. So on that one page that had all the little buttons, one of them was contact your legislators. If you hit that button, there you go, pops up usa.gov. And this is how easy it is to find. You literally go and you can see the links. You could even how to reach the President of the United States. I'm not sure he's going to read your letter, but someone on his team might. But you can also click on U.S. senators or U.S. representatives. You can even go down to state and territorial elected officials and click on those, or local elected officials. This is the type of information that is at all of our fingertips. We need to take advantage of it. And if you go to websites similar to mine or the Spondylitis Association of America's website, you will find these type of tools to help you. So what would it look like if you clicked on, and I circled it in red, U.S. senators? This is what pops up. And so with these drop-down arrows, it's easy. You would choose a state. And if you choose the state, when you choose that state, the 2 senators in your state will pop up. Or if you have more than 2 senators. But in the state of Florida, we have 2 senators. If I clicked on choose a state, went down to the state of Florida, the 2 senators will show up. Or if you click on the drop-down arrow that says choose a senator, that will list all the senators in the country. You could even, where it says choose a class, that will tell you what the term limits are to the various senators. You can do the same with this when it comes to your House of Representatives or your state and local officials. Now you say, okay, fine. It's easy to get a hold of my legislators, but I don't know what to write. I don't do this all the time. That's okay. Once again, I'm going to use my website as an example. You would hit the tab that says sample letters on the issues. And right now I have 9 different issues that I have template letters, whether it be a copay accumulator protection program, step therapy, prior authorization reform, PBM reform, all of these, there are letters. If you go to the AMA, if you go to the Spondylitis website, different websites that focus on these issues most of them will have sample letters. And you can read this letter. Basically, it says why you're writing to the legislator, type of illness that you have. With this one, is for prior authorization, what it would mean if they supported making these changes, how it would cut down on excessive paperwork, it would stop fail first approach. Basically, it spells out everything you need. All you have to do is put in your name, who it's addressed to, and say thank you. That's it. That's how simple it is. And look, let's focus in a little bit more, getting a little more granular with healthcare. Look, advocacy in healthcare is super complex, and it takes many forms around various issues and players. You can advocate for yourself or others with your healthcare team. And when I say that, what I'm saying is don't do this alone. If you have a physician's practice that you go and see, they will be on your side and you need to leverage them. They are your healthcare team. But sometimes you may feel like you're talking to them, but they don't hear you. So you may have to advocate for yourself with your healthcare team. And we're going to get into that. And another one, which I do all the time, is battling the insurance companies around issues such as prior authorization, utilization management, coverage denials, affordability, you name it. But advocacy in healthcare comes in many forms. So let's step back for a second, make it personable. So say you're having to advocate with your own healthcare team. Look, at the end of the day, physicians and their staff are under immense pressure. Today's healthcare environment, they are squeezed for time. They are squeezed for finances. They're getting reimbursed less. The administrative overhead coming from the insurers makes it brutal. Some of them are being held to how many patients they have to see a day. So there may be times when you or your caregiver feel like, wait a minute, they're not hearing me. They're not listening to what I say. That is when you need to advocate for yourself. Or if you're a caregiver, advocate for the patient. So what are some ways when you're doing this that you can bridge the communication gap between yourself and that healthcare team that you're working with? The first thing, and I learned this in a podcast, a few podcasts ago, I interviewed this lady and her husband was a heart transplant patient. And this journey took them 20 years. And she was amazing, gave stories about her husband going to the hospital, how she had to advocate for her husband. And one of the things that she said that I loved was, you have to be the captain of your healthcare team, not the doctor, not the nurse. Doesn't matter if it's in a physician's practice or in the hospital. You, the patient, or your loved one who's the patient, has the most to gain and the most to lose. So you need to be in charge of that healthcare team. Always, always do your homework and be prepared when you're going to see your healthcare practitioner. You may hear the term HCP, that means healthcare practitioner. That could be a pharmacist, a doctor, a nurse, a physician assistant. But when you're going to talk about an issue, when you're going to ask them to do something for you, you need to be prepared. You need to do your work. And if you do that, they will appreciate it and they will take you more seriously. Also, something that when I talked to Val, the lady that I mentioned who was an advocate, I loved her idea of taking notes. You need to take notes. Healthcare is complicated. You need to take notes and you need to ask questions. And if you're confused, you need to ask for clarification. The last thing that you want is you walk out of your physician's office and you get on the phone and you call your mom or you call your daughter or a friend and you're frustrated and you say, I just had my appointment. They didn't tell me what I was asking them to do. They didn't really understand what I said. And guess what? You may not see them for 2, 3, 4 weeks from now. Do not let that opportunity go by. And if the physician's in a hurry, then just say, well, if he's leaving, can I speak to a nurse? Can I speak to the office manager? You do not leave that office without getting the clarity that you need and making sure they know what you need. A couple other tidbits to remember: keep a log of all pertinent items. What are the medications that you're on? And are they working? You want to always track your symptoms, whether you're improving, whether you're staying stable, or whether you're declining. You need to write these things down. And I think another great golden nugget is have a timeline of your healthcare journey. You know, you're going to turn around and before you know it, maybe you've been on this journey for 3, 4, 5, 10 years. Well, it'd be nice if you tracked your journey, the medications that you're on, how your condition progressed or stabilized or got worse, and you were able to paint that picture. Having all of this, believe it or not, the healthcare practitioners appreciate it, they respect you, and they will listen to you. And lastly, I cannot reinforce this enough. Establish a relationship with everyone in that physician's office, whether it's the physician, the PA, the nurse, the office manager, even the receptionist. I'll tell you, years ago when I got into the healthcare field and I was a pharmaceutical rep, You'd go to physicians' offices, and there were some offices you just could not see the doctor. And so what you did was you got to know the only person that would talk to you, which was the receptionist. And you got to know them. You ask about their family. How are they doing today? Maybe once in a while you drop them off some cookies. You just do something. You develop a rapport with them till you had a relationship. And then you basically would say, hey, I really got to see the doctor or the nurse. I know it's hard to get in there. Does anybody else get in there? What do they do? Is there a time of day that's good? Is it good at lunch, breakfast, after hours? What can you give me, or how can you advise me? Because it's really, really important. So do not take anyone for granted in the office. Treat everyone with respect and gratitude. As we always know, sugar gets more, and honey get more than salt and pepper. So always be sweet, always be nice, always have gratitude, and you will be shocked at how much they will do for you. So my favorite thing, battling with an insurance company. So look, I think we all know this. It's in the news. Healthcare has turned into big business, and insurers and their PBMs, or pharmacy benefit managers, use various techniques to deny and delay care. And I can tell you point blank right now, that is a strategy. The longer they can deny, or actually just delay care, the less they have to put out in healthcare services, and the lower the cost for them. So they're going to do that. You and your caregiver have to expect to fight for everything you want and everything you actually deserve. You pay for insurance. You deserve healthcare, and do not accept no for an answer. And here's some crazy statistics. Every year, insurers deny tens of millions of requests for care. And as I said, that is part of their business model. Unfortunately, the bad news is when people get denied care, and what I mean by that is your physician says, you need this medication or you need this procedure. And they say, but I need to get it authorized by the insurance company. And it comes back and it's declined. Less than 1% of people will appeal the insurer's denial. Less than 1%. The good news is, of the people that do appeal a denial for insurer, over 80% of those appeals are approved. So think about it. If you're an insurer and you know that you're going to save money by denying care or delaying care, and you know that 99% of people, if they're told no, will give up, you're doing that. That's good business. What the 80% of appeals that are reversed or are approved if they're appealed, what that tells you is they know that the patient deserves that drug or that procedure or that service. And all you have to do is say, I don't accept no. I'm going to appeal this, and do that. Now, look, you're probably saying, wait a minute, that's too much. I can't do it. There are 3 keys to successfully appealing denials, and we're going to walk through all 3 of those. The first one will be doing your research. The second one will be knowing your rights. And the last one, which we'll touch on and expand upon, is leveraging all the available resources at your fingertips. So the first one, when battling your insurance company, do your research. So look, every carrier, when I say carrier, I'm talking the insurance companies, they have guidelines and protocols on how patients and physicians can can appeal a denial. So they know this is part of what they have to do. They are, by law, they have to put on their website what steps a patient or a physician can follow. Then what you need to do is work with your provider for guidance. Let me tell you, your provider, your physician's office, they're used to working through the appeals process. They do this every day for a ton of their patients. So they should be able to give you some great advice and guidance. Also, use the internet to gather information to help to present your case. You are going to have to present your case of why what they told you they don't want to give you, that they need upon your appeal, that they need to give that to you. You're going to have to state your case. And lastly, talk to friends and family and see if they have any advice. See if they have any experience in this. I can tell you a great story I had a great buddy of mine a couple years ago. He had to go to the hospital. It was over Thanksgiving holiday. He had horrible intestinal pain. He went in there, and after a couple of days, they figured out he had a colitis attack. And so basically, I was calling him back and forth, and he was like, I got to have the surgery, et cetera. And I'm like, well, ask the doctor what that looks like, what your surgery is going to look like. Because I've been in the healthcare field a long time. Well, he got back to me and said, look, he's basically going to have to resect or take out about a foot of my colon. He's going to have to do an incision from sternum to my belly button, and it's going to be about a 6-week recovery. And I'm like, whoa, time out. My brother-in-law just had this exact procedure done 6 months ago, and they did it laparoscopically. 2 small incisions. They resected 15 inches of his colon. He was up and running in 2 weeks' time. And so my buddy went back to that surgeon. The surgeon said, yeah, that's one option you can do. I'm used to doing it this way. And he's like, well, I don't want to have a 6-week recovery. I don't want to have a huge scar on my stomach. I don't want to have a higher chance of infection. He ended up getting a second opinion, had it done laparoscopically. You don't even see his scars. He was golfing 3 weeks after the surgery, and much less chance of infection, much less chance of complications in the hospital. Do not be ashamed or afraid if you have a health condition. Everybody gets them. Everyone's going to be a patient. You need to talk to friends and family to see if anybody has advice for you. The second step in battling an insurance company is know your rights. We already talked what they're going to have on their website as far as ways to go about an appeal of a denial. You need to know there are federal and state laws that provide patient protections. Most people don't know about it. The insurance companies certainly aren't going to tell you about it. Look, bottom line, all you need to do is go to the internet and research your situation and your rights. Say what state you're in, what your condition is, who your insurance company is, what the situation is. Are there any rights that I have as an American citizen, as a patient with this situation? Also, work with your provider office. They will be able to give you help and guidance. And lastly, if you've tried all these things and everything else fails, reach out to an elected official, reach out to the local news station or the media to get help. There are so many ways to do this. We all need to fight for what we deserve and what we have paid for. So I'm going to get kind of excited about this piece because this is something that in the last 8 months, I've really gotten better at, which is leveraging all available resources. We've already talked about your provider office. That should be one of your first resources, your family and your friends. Advocacy organizations like the Spondylitis Association of America. These are great organizations. They advocate for their patients all the time. They have all these resources. You need to leverage those. One thing that you can do, and it is amazing, and we're going to walk through this, is AI, or artificial intelligence. And I will tell you right now, you need to use AI, because if you want to have a chance against insurers or hospitals or anyone else, they are already using artificial intelligence to deny and delay care. That is already being used. It's one of their tools. And if you're not using those same tools, you are at a disadvantage. So you may say, oh, cool, I use AI all the time, I can do that. Or you may say, what in the world are you talking about? I still have a typewriter in my house. Look, there are different models of AI or artificial intelligence. I like ChatGPT, but there's others such as There's others such as Gemini. There's another one called Perplexity, but there are dozens of these different type of tools. You just need to use what works best for you. They are free. They come at no cost. That may not be the case in 5 years, but right now you can use them free. They're extremely intuitive and they can do just about anything. The more I use them, I am just blown away about what a phenomenal tool they are and how much they help. So this is what I wanted to provide to you. You're going to get these slides, and I wanted you to see what will it look like if you go to the internet and you just type in www.chatgpt into your web browser. So what will pop up is a number of different sites, and I've already circled in red. What you want to look for is chatgpt.com. So you'll click on that. You'll see some options pop up. You don't need to subscribe to it. You can stay logged out. Boxes will pop up that you will type in what you want. One thing I want to stress is do not put in any of your personal identification. It will not ask you for your personal identification, but do not put in your name. Do not put in your social security number, your address, your phone number, nothing. All you're doing is putting in the information that you need to create a letter of appeal and follow the prompts. So when you click on ChatGPT, what will pop up? So what pops up for me is the welcome back, because I go to it a lot. Now, I could click on continue with Google or Apple or Microsoft if I had subscribed to it. I hadn't subscribed to it, so I just go down to the very bottom where it says stay logged out, and I click on that. When I click on that, to the right where you see the box, that's what pops up. That's the next screen. Where should we begin? Ask me anything. And that is where you start to put in information. Now, for this exercise, I don't have ankylosing spondylitis, but if you do, and you're like, you know what, I want to get a certain drug, and they said no, so you want to create a letter of appeal, what you do is you go to your physician, you say, hey, I want to create a letter of appeal using ChatGPT, and I need my medical records that will help me put that together. And so you own your medical records. Ask your physician for that. They'll give it to you. And we're going to walk through what that looks like. So this is where I just start to get excited. So I don't know any of you, and I'm not an AIC-SPON patient, so I can't go to my doc and ask for it. So I basically went to AI for this example and this presentation, and I said to AI in the box, give me a typical patient description of ankylosing spondylitis patient who's had the disease for 5 or more years. They have moderate to severe disease, including the symptoms they have and the medications that they are on. Within 30 seconds, you can see the 2 boxes. It gave me an example of a patient's history of their illness, their physical exam, including their posture, spinal mobility, peripheral joints, active synovitis, different things as far as their labs go. It also included their current medications. Now, this is just an example, but I asked them for a typical patient, what type of meds they would be on, etc. And it gave me all of this. This should give you an idea of how amazing and quickly artificial intelligence and something like ChatGPT can do. And look at the summary. Mr. AB is a 35-year-old man with an 8-year history of ankylosing spondylitis. He has moderate to severe disease with chronic inflammatory back pain, restricted spinal mobility, and radiographic progression. He's currently managed with NSAIDs and a TNF inhibitor, which is adalimumab, with partial symptoms controlled but ongoing functional limitation. So this, just so you know, was put together from what I asked in less than 20 seconds. So all those slides that I just showed you the information that when you want to do an appeal letter, now you know what you need when you go to a physician's office. I need my medications, I need my history, I need my symptoms, etc. That's why I wanted to do these screenshots for you. So then I said, okay, to the ChatGPT, I said, could you please use the above information, all the patient history, to give me an appeal letter for an insurance company's denial of Stelara, as my symptoms currently are not being controlled by my current medication. So basically, the AI has the description of the patient, which would be me. They have the appeal letter that basically Stelara was denied, and I would like to have an appeal letter because what I'm currently taking isn't controlling my medications. I hit go, and here you go. Dear medical director, I'm writing to formally appeal the recent denial coverage for Stelara, blah, blah, blah. It goes through the clinical summary, goes through the treatment history, the medical necessity for Stelara. So within seconds, it typed up this very well written appeal letter to the insurance company. It gives a summary. It gives the request based on the above. I strongly request coverage for Stellar to be approved as it represents the most appropriate next step therapy, etc. And then, and this is how AI works, it automatically prompts and says, would you like me to customize this letter with your clinic letterhead? So if your physician's office wants to do this or will do it for you, they can put their letterhead on it, and the specific insurance company language, including their policy section based on prior authorization. So it can proactively do all of these things. And not only that, this is for a letter. Lastly, it says, would you like me to generate a shorter version that would be more suitable to submit through an insurance appeal portal? So say you want to, instead of sending a letter or an email, you want to submit it through the insurer's portal. And the insurer's portal says, you know what? It has to be under 500 words. Well, then you would just say to ChatGPT, could you make that appeal letter less than 500 words? And it will compress it and summarize it in less than 500 words. Yes, this is mind-blowing. It gets me very excited. I tell people about all this stuff. It is super easy to use, and you have all of these in the slides to look at and help walk you through this process. So look, we're going to wrap up, and just a couple take-homes from this. First off, hopefully you realize now that advocacy is not hard. We do it every single day. And at the end of the day, what do you have to lose? They've already told you no. All they can do is tell you no again. But as we saw, 80% of the time, if you appeal a denial of something your physician has prescribed, 80% of the time, you're going to get a positive outcome. Once again, we do this every day. There are plenty of tools out there to help you. And look, we can't be a victim. We have paid for our health insurance. We need to stand up and demand our rights and the services that we've paid for. And lastly, if you don't want to do it for yourself, do it for everyone else. The more that we fight the system and advocate for ourselves and don't accept no, the better chance that we have to fix our healthcare system. And with that, I'd like to say thank you to everyone. I really appreciate the opportunity that the Spondylitis Association of America has given me. I hope you're enjoying the program, and I'm available for a Q&A. Thank you.
Hi, everyone. Thank you for joining us today. I'm Melissa Velez, Programs Director at the Spondylitis Association of America. I will be moderating our Q&A session today. And before we get started, I'd like to introduce our panelists. Dr. Abhijit Dambe is an Associate Professor of Medicine at Yale University and Founding Director of the Yale Spondyloarthritis Program. His work focuses on improving early diagnosis of axial spondyloarthritis among people with chronic back pain. Chuck Melendi is the founder of Disruptive Dialogue. He brings 25 years of experience in drug pricing and health policy and has deep insight into navigating the U.S. healthcare system. We also have two patient advocates on the panel today. Rick Phillips was diagnosed in 2015 after living with spondyloarthritis symptoms for decades. He offers great perspective on persistence and resilience. And then we also have Minnie Wilson. She is the co-leader of SAA's support group in Raleigh and Durham. She lived with symptoms since childhood and now focuses on advocacy and support for others. So thank you all for being with us today. So question one, Dr. Dambe, what are some of the key signs that suggest back pain may be inflammatory rather than mechanical?
Sure, Melissa. I think for the most patients, diagnosis of axial spondyloarthritis, the journey begins with back pain. So 95% patients start having back pain, and it has some peculiar features. Typically, it starts at young age, mostly before age of 45. It is gradual in onset. So people don't really have an event and then they start getting back pain, although they sometimes may try to attach it to an event. So it gradually gets worse. In most of the patients, the pain is better when they are more active with movements, exercise. The back pain is better with movements and exercise. It does not get better with the rest, which is exactly opposite to the mechanical back pain. Usually there is morning stiffness for more than 30 to 45 minutes. The back pain actually can wake them up from sleep. So many patients will tell us that, well, my sleep is disturbed. I can go to sleep, but in the middle of the night, I have to wake up because my back is really stiff, achy, and I have to get out of the bed and stretch. Then I feel a little better or not. And other thing is the inflammatory back pain gets much better with NSAIDs for most patients. This may be one of the reasons people, take over-the-counter Advil or Aleve and keep going without getting to the doctor with the symptoms. So inflammatory back pain can be distinguished from mechanical back pain with some of the features.
Okay, great. Rick and Minnie, I want to ask you guys, if you could go back to when the symptoms first started for you, what would you tell yourself? I'll start with Minnie first.
Yes, when my symptoms first started, I would tell myself to keep going, which is the advice I give other patients during my advocacy work. I've realized over time that I've survived every single bad day, and to just keep going, that I can get through it and not to base tomorrow on yesterday, because the symptoms come and go, just like a headache is that it can be that quick or longer, but you just don't know, but just keep going.
Rick?
I would say keep moving. One of the best things that I ever did was buy a set of walking poles. And these walking poles keep me walking. My wife and I like to walk, and we do it a mile and 3/4 each day. We do it summer, winter, all 4 seasons. And it is the one sure thing that I can do that helps alleviate the back pain.
Dr. Dombey, how is axial spondyloarthritis diagnosed when X-rays or blood tests are normal?
Well, we get this question often. As all of us, we want a definitive objective test that shows it may be a blood test or an X-ray or MRI. So the diagnosis, so gold standard for diagnosis of axial spondyloarthritis is clinician's judgment. Similarly, gold standard for diagnosis of diabetes is blood sugar level or hemoglobin A1C, which is a test. But here, it's actually a pattern recognition process. So we look at the patient's symptoms, especially the back pain, and if they have any other extra musculoskeletal features like eye inflammation, skin psoriasis, Crohn's disease, or GI symptoms, we often ask them about their family history. This actually helps us a lot, much more than any test. So 65% or 70% of our suspicion is formed with thorough history taking and the family history information. Examination can help some. To answer your questions, if somebody has normal X-ray and negative HLA-B27, which can happen, we could get MRI of sacroiliac joints, and many times we are able to identify the inflammation, especially at early stages. Sometimes though, especially in some age groups, especially like adolescents and kids, second is women, the symptoms are vague and widespread. So you really have to ask them about the history of plantar fasciitis, tennis elbow, rib cage pain, belt line pain. These all are suggestive of inflammation of the tendons or ligaments. And the diagnosis is actually a composite diagnosis looking at the broader picture rather than by one blood test or one X-ray report.
Just to piggyback off what you mentioned about women, we did get this question on Facebook. What do we know about how axial spondyloarthritis presents in women?
Sure. So there are some differences when it comes to axial spondyloarthritis in women. A good thing is women radiographic progression is not as much or as fast as in men. But what happens with women is the symptoms are not very typically focused on the lower back. Sometimes they may present with mid back pain or neck pain. They frequently have widespread pain more, for example, costochondritis or rib cage pain, the other joint pains, and it almost feels like they get misdiagnosed with fibromyalgia because of not having very typical inflammatory back pain. The other thing is the symptoms may not be as severe and they go on for a long time because it gets misdiagnosed as many different things before a physician identifies that this could be inflammatory. So the other thing is women tend to have more non-radiographic stage of the disease as compared to radiographic stage. And these are some reasons it gets delayed more, the diagnosis gets delayed more in women as compared to men. And there are some differences when it comes to the response to the treatment and cycling through different biologics.
Minnie, did your experience reflect any of what Dr. Dombey just said?
Yes, absolutely. You just don't know what you're going to be faced with from one time to another. But yes, I've had all of the symptoms that he's brought up, and I've just gotten accustomed to just pushing through, focusing on what it is that I have to deal with at that time, and just trying not to overwhelm myself, because it is very easy to become overwhelmed and deal with depression from just worrying about what you have to deal with your body. So I just keep pushing through.
Did you have a long diagnostic delay?
I had a very long diagnostic delay. I was diagnosed at the age of 37, despite having symptoms all of my life. When I got to the age where I was driving and working, I started taking myself to the doctor, just trying to figure out what was going on, because my hip pain was so sporadic, and then it became very persistent. And, walking with a limp when you're in your early 20s is kind of, people pointed out to you all the time. And so I knew something was wrong, but then I started convincing myself that maybe I wasn't in pain, because people tell you, you're too young to be in all that pain. So I found myself believing that and convincing myself I wasn't in pain, but it took a long time. I'm glad I did not give up on myself, and I'm glad that I've been able to be a backbone for others by sharing my experience so that the research has changed and we can see improvement in the treatment of other patients.
Very good. Thank you. Chuck, several of our registrants described seeing multiple providers over years before receiving answers. From a healthcare systems perspective, what contributes to diagnostic delay in inflammatory back pain?
Sure, and we just heard Mimi talk about that. You know, the challenge in the U.S. healthcare system is it's just so fragmented. You know, first off, diagnosing, as you heard Dr. Donby talk, diagnosing common back pain is difficult at first. You know, most physicians, especially if you go to a primary care physician, they're going to lean toward like a mechanical issue, like a strain, a disc, posture. So they may send you to PT, give you some pain medications. But we need to realize that you may be going to a primary care physician or an orthopod, pain management PT, but they're really, till you get to a rheumatologist, there isn't a physician that is overseeing everything and can see the full picture. And I think that is key. So, you know, the first reason is just our system is built this way. It's just very fragmented. I think secondly, like we just said, before you get to the specialist, most are assuming that it's mechanical. And as you already heard, early inflammatory disease is very challenging to detect. So we've heard this during the talk, is when you go see your physician, and right off the bat, whether a primary care physician or a clinic, you want to specifically ask about inflammatory back pain, especially if you have symptoms. Like if you had back pains before the age of 45, if your morning stiffness lasts for more than 30 minutes, if you improve as you move, those are things that you wake at night. You heard the physicians mention that a few times. These are key things that you want to express right off the bat to help the physician. One of the things that I have found over the years is physicians are super busy. They have so many patients. They care, but patients put too much dependence on the physician to figure it out. And what I have told people on my podcast and everything is, you have to be the captain of your healthcare team. You have the most to gain and the most to lose. So if you don't like your physician, go to a different physician. If you're confused, ask questions. Keep a written documentation of your symptoms, of your journey. You may turn around and you've had a condition for 5 years and it feels like 2, but when you go through that, you start to see trends. All these things, I believe, will help you accelerate your journey through the healthcare system.
Dr. Donby, yeah, do you want to add to that?
Yeah, Chuck, you are speaking my mind. And it is so true. So the most important, I think, point that you are telling is the patient really needs to be active participant in this whole process rather than be dependent on the primary care physician or other physicians. The other thing that I feel is we all, when we get into medical school training and then we start practicing, we have worn our own glasses. So when a physiatrist goes in, they are looking at where can I inject, which nerve I can ablate. When a spine surgeon goes in the room, they are thinking, what can I operate on? So as you said, rheumatologists and internal medicine doctors are more holistic. They look at the bigger picture. But what happens with our internal medicine colleagues and the family physician colleagues is they have so much to do in that 15-minute window period that our insurance system somehow gives us to see a patient. The patient, it's important for patients to bring to the attention of your physician that today my appointment, I would like to discuss more of this XYZ problem. And then you need a written document and rehearse or like do some homework before you go in so that the physicians can understand the nature of the back pain. Otherwise, what happens is the primary care physicians have so many things to do. They will order an X-ray of the lumbar spine, not sacroiliac joint. They'll send you off to the physical therapy and that's it. And when you get an MRI of the lumbar spine, you have to first wait for 6 weeks because the insurance company will not allow it before that. And the MRI of the lumbar spine will miss the sacroiliac joints, where that's where the diagnosis is hidden. So I think an active participating patient is very important. A well-informed patient is very important, as Chuck said.
We absolutely believe that at the Spondylitis Association as well. Education, knowledge, that's power. So, so Dr. Dombey, go back to you. So what does the first appointment, let's say they got a referral from the PCP to you, what does the first rheumatology appointment look like?
Sure. So unfortunately, in the current situation, our wait times are long. When we go in, usually our nurse goes in and then they do the medication reconciliation, take vitals. What we do when especially it comes to back pain or widespread pain issues, we ask our patients to tell us about how long they have been having these symptoms. Are there anything that makes it better or worse? Have they tried any medications for that? What all specialists have they seen for this problem? What all interventions or like medications, steroid injections, epidurals, nerve ablations, etc. they have gone through, whether that has helped them or not. What was the reason for them to wait for so long before they come to us? For example, like you have been having back pain for say 10 years and now you are seeking attention. Is it that it was mild before and now it has gotten worse? Is that the reason? So I have had patients who were popping Advil for years and years, like say let's 15 years. Then what happens is they are diagnosed with some GI condition, say peptic ulcer or inflammatory bowel disease, and that becomes a contraindication to taking Advil. That's when their symptoms flare up. The other symptoms flare up, and that the diagnosis is uncovered or unmasked at that time. So we go through the patients, like we basically ask open questions and let the patient speak. We definitely go through their extramusculoskeletal manifestations, especially eye inflammation, psoriasis, IBD, and family history is very important. Also, it's not only the lower back. People can have neck pain and mid back pain for a while, which is blamed on cervical spondylosis or posture or many other things. So a thorough interview and detailed history is way more important, especially when it comes to axial spondyloarthritis and psoriatic arthritis.
We just had a question come in. Somebody was asking, what can they do? And Chuck, this Dr. Donby, it's probably is a question for all of you. What can people do if they're in an area where they don't have access to expert medical professionals?
Sure. Maybe I can take this. So what we have been doing for last more than 10 years is we realize this challenge of access or this vague nature of the symptoms. So, and not every back pain patients can go to rheumatologist, right? Or every widespread pain patient. So we really need to create a filter. We need to create screening. We need to be able to get the patients with high suspicion in rheumatology offices. And I have been studying this area for 10 years, as I said, and we have now created a screening survey or screening tool for the patients with suspected axial spondyloarthritis. Using our survey, we feel only 3 or 4 patients need to be seen by a rheumatologist to get to the diagnosis. The second aspect about the access is, I think telehealth or telemedicine is becoming more and more prevalent. One good thing about spondyloarthritis is even if I have a patient in front of me, on examination, there's nothing to be seen. Cannot examine for inflammation in the back joints or sacroiliac joints for the most part. When they have the inflammation of the joints in the extremities, it is usually fleeting. As Mimi said, it comes and goes. So when you see the patient, it may not be there. So what I'm trying to say is majority of the times, I could make a diagnosis of axial spondyloarthritis just by history and looking at their X-ray or MRI myself and looking at their blood test myself. So the patients should use more and more telemedicine type of access with a larger university place in their state wherever they are. That could be one of the solutions for this.
Melissa, one thing I would add to Dr. Danby, and telemedicine was one of the things that came to my mind, is seriously use the internet. We didn't have this 30 years ago. If you just type in rural health networks, or I live in a rural health area and I can't find a specialist, what organizations can help me? It'll pull up organizations. You can connect to that. You can find out what's required in your state. There's so many resources available. You just have to ask the internet and always do your homework. But yes, telehealth and I think using the web can help you in those situations.
And I think SAA is doing a great job. On the SAA website, there are experts in each state who can help and serve the patients with spondyloarthritis. And I think the network is growing, if I understand correctly.
Yes, we do have a rheumatologist directory.
Yeah.
These are actually rheumatologists that have been recommended by patients who have spondyloarthritis. So they've seen these rheumatologists, they feel seen, heard, and that's what we want. So very good. Let's go to Rick. Rick, what was the hardest part of the early diagnostic journey for you? Did it take you a long time to get diagnosed?
Yeah, it took a long. I didn't even know what it was until I got diagnosed. I mean, I never heard of it, and the surgeon said, "You have ankylosing spondylitis," and I'm like, "What? What's that?" I mean, I'd never heard of it, and looking back on it, it made sense. This had been a process for years, and I'd spoken to doctors about it. They had never said ankylosing spondylitis. Nobody had ever said anything. I had to go look it up. So probably the toughest thing was trying to spell the darn thing. And, I looked it up and I was just flabbergasted. I was like, what? And then the second toughest thing was trying to explain it to somebody. Ankle what? And I don't know that I can even explain it now. It has such diverse symptoms and diverse issues that it's very difficult to talk to other people about. And it's just such a multifaceted condition that it is really, it's very difficult to talk about. And because it's not one thing, it's a broad spectrum of things. In terms of my personal life, I've got many other issues, and so we did exactly what we do with. I say we, my wife and I. We do exactly with what we do with all these things. We have a good cry, and then we figure out how to go on. And I don't know how else you do it.
Thank you for that. Dr. Dombey, he touched on something, other conditions, and we also hear this from other, individuals and members of our community, that there are other conditions that can go along with this. I know they touched on that in the presentation, but I know particularly for inflammatory bowel disease and for psoriasis, those sometimes can go hand in hand. Can you talk about that? And in the sense of somebody may have psoriasis symptoms before they develop spondyloarthritis. So
Sure. So to answer Rick's question, the ankylosing spondylitis, and now we made the name more complicated. We call it axial spondyloarthritis. We are trying to abbreviate it by calling AxSpa. So if that makes any helpful suggestions there. What happens is patients, the axial spondyloarthritis comes in a group of problem. The group is called spondyloarthritis, SPA, S-P-A. And it has 4 different diseases: psoriatic arthritis, axial spondyloarthritis, inflammatory bowel disease related arthritis, and reactive arthritis. So sometimes it could look like psoriatic arthritis because patients develop psoriasis first or inflammatory bowel disease first. And after a few years, they can get back pain or inflammatory arthritis. Or some clues that I would like to give is when patients are in a physical or emotional stressful situations, they may get more flaky scalp. There may be more flaky skin behind the ears. That kind of suggests, or some flakiness at the elbows. That can suggest a psoriasis. And if they also have been having back pain and morning stiffness, then they can put two and two together. The other conditions that go along with this is, especially in women, hidradenitis suppurativa, or HS, is another skin condition that can go with these patients with spondyloarthritis, either psoriatic arthritis or axial spondyloarthritis. In young folks, what else can be associated is if somebody had bad cystic acne that they dealt with for a long time, that can be one of the connection with axial spondyloarthritis. And there's a medicine that's given for cystic acne. It's called Accutane. The Accutane itself can cause an illness similar to spondyloarthritis. So these are some subtle points that we are always looking into, and we let patients talk, and then we are trying to find the pointers in their health journey that can help us in figuring out if this is spondyloarthritis. The last thing that I would like to say about this is, see, if somebody has back pain for 8 years, 10 years, they change their life around it. They stop wearing shoes with shoelaces and they get slip-ons, or they are like changing the whole thing. And then when we offer them treatment with a biologic, which may have some side effects, patients are in this confusion. Well, is it really necessary that I should take a biologic for something that I have been dealing with and managing this for last 8 to 10 years? And that's another challenge that we face in the practice, because patients usually downplay the back pain a lot.
I think we have time for one more question. Chuck, we received a lot of questions about insurance, access barriers early in the journey. So what type of insurance or access barriers should somebody anticipate in their journey, and how can they move through them?
And we just have a few minutes, huh? This could go for hours. So here, this is all my opinion and from what I understand. So first off, I look at it in two buckets. If you're 65 or older, if you have inflammatory disorders, you're going to have some illnesses and need treatments and services. I would recommend, if it was my mom, to go to traditional Medicare. While the premiums may be a little bit more expensive, the out-of-pocket is much less. Now you want to have a supplemental insurance to cover the additional 20%, but you have nationwide coverage. You have very few prior authorization issues you have to deal with versus Medicare Advantage. Not everyone will agree with me, but from what I've seen and heard in research, if you're 65 or older and you believe you're going to have a chronic illness, traditional Medicare is probably the way to go. If you're already over 65, then you're in Medicare Advantage, and so you're like, well, I want to switch back. If you cannot get supplemental insurance, that will be challenging. They have actuaries. A couple things have happened. I'm going to get in the weeds real quick. Like out of net, like say you're hearing how Medicare Advantage organizations are losing money, so they're slimming down their networks, they're going out of certain counties. If that happens to you and you lose your MA provider, there's a 63-day window that you can actually go back to traditional Medicare and guaranteed normal cost supplemental insurance. So that's something that people don't realize. There's also 4 states in the country, New York, Maine, Massachusetts, and Connecticut, where you can go from MA to traditional Medicare and be guaranteed your supplemental insurance. So if you're a senior citizen, that is super important. If you are under 65, you're going to have to deal with insurance or the ACA marketplace. Look, at the end of the day, the system currently set up is to delay care. They make more money if they're not treating people or they're not paying for what has to get done. What you need to do is be super prepared. I said it in the talk earlier. Use artificial intelligence, ChatGPT. You can go on and say, like, I'm just gonna say you have Aetna. You can go on the Aetna website and you can say, what is required for me to go see a rheumatologist? What symptoms do you need to see? If I want to get X-ray, but you should always get an MRI or something else to go along with that. but you want to know your documentation that you are going to need as soon as possible. You want to have your journey documented. You want to just really follow up on everything. If you have a physician's office, work with them. They are professionals. They do this all the time. You can, I said a statistic earlier in the talk, which was, tens of millions of prior authorizations are denied every year by insurance companies. Less than 1% of people try and appeal those. Less than 1%. So insurers know 99% of people will not try and appeal a denial. Well, for those 1% that try and appeal the denial, over 80% are accepted, which means they are denying care that should be given. It's just a business model to deny it and see who appeals it. So when you do appeal it, work with your physician's office, document everything, make sure you put all your inflammatory disorders in there, your journey, what you have failed on, etc. And those type of things will help you. And if that doesn't work, then go to patient advocacy organizations like yourself. Y'all can give them great advice. And at the end, go to a legislator if that doesn't help.
Okay, thank you. Unfortunately, we're out of time. We could probably spend hours and hours and hours talking about these different subjects. So I want to thank all of our presenters and our panelists for sharing their expertise with us today. We appreciate you so much. I would also like to thank AbbVie for their support of this program through an independent patient education grant. So if you're still wondering whether your back pain could be inflammatory, we want to encourage you to visit our website, look at our resources, take the axial spondyloarthritis screening tool that Dr. Dombey has created that's available on our website now as well. And just stay in touch with us. We are happy to help this community as much as possible. So come visit the Spondylitis Association's website for more information. So thank you. Thank you to everybody. Appreciate it.
Thank
you
you
very much.
Thank you.